of my presentation is the Neuro-immune Connection in brain-related clinical conditions. So let's dive right away into it. One of the most important discoveries over the last 20 years was the relation to establish the relationship between the nervous system and the immune system. This is a powerful system, and I consider this establishment and this kind of research one of the most important things, particularly with relevance to clinical conditions. Because unless you consider the human body as an integrated unit, you really go nowhere in your diagnostics, but also in your therapy. So next slide. It has been now established that inflammation and oxidative stress play a powerful role, if not the role, in the origin of well over 100 different clinical conditions. And this is very important to keep this in mind. But remember, this is something relatively new. It has been firmly established just over the last 5 to 10 years. So that means we never can forget and should not forget by working up of a patient that there is this powerful system which we call the Neuro-immune Connection, which is critical for the patient's health. Next slide. The nervous system as such is a powerful system. It is ubiquitous in the body. And it is not just connected or established for the brain. It is really throughout the body. And this is what many people forget. The nervous system is as powerful in the periphery as it is in the brain. And it's clearly there is no separation between the nervous system of the periphery and the nervous system of the brain. It's one and the same unit, and they're all interconnected. And it shouldn't come as a surprise that this kind of a system also has a powerful connection with the immune system. We have an immune system in the brain, which is slightly different from the immune system in the periphery, but still, both are well connected. We do not fully understand yet how those systems are connected, but at the moment, we all have to accept that there is some powerful signals going back and forth between the brain immune system and the peripheral immune system. So what are the consequences of the so-called neuroimmune supersystems? At this point, we cannot be sure that really what we had established in the past as a separate units and entities of neurology or immunology, that these are truly a separated system. The more I study that, and I've been doing that for the past 15 years, the more I come to the conclusion it's really one and the same system. It's just that two different sides of the same coin. So, which really is important when we start diagnosing a patient. The selection of the disease relevant lab markers for both systems is paramount. So you have to keep this in mind. When a patient comes to you, you immediately have to look at of course, now the patient comes with particular complaints or conditions. And then the question for you as a physician is, where should we start? And what's important here? So, but you definitely, and I made this a routine even for my own work, to immediately check, are there any neuroimmune issues involved in the particular clinical presentation of the patient. And we also should not forget, particularly these days, where genetic SNP markers came into vogue, to check those things out too. So this is my point on the diagnostics. We should ask the right question, and we should establish the relevant diagnostic markers. are not just the markers which have a relevance to the complaint of the patient, but you as a physician, you should know roughly what could be behind a particular complaint. Also, therapeutically, you have to consider, even if you don't do testing or you do not check out any lab parameters, you should keep in mind that what appears to be on the surface is not necessarily what's going on a molecular level. So if you consider both systems, then this is really the guarantee to see improvement with the patient in terms of your therapy. And in some cases, you see even cures. Next slide. Here again, this slide illustrates that the clinical manifestation does not necessarily point in the right direction, because as different systems in the body, we have to consider the endocrine system, we have to consider the nervous system, the immune system, and now we also have to consider the enteric system as the source of a problem. So I think it's those four super systems that always should be on your mind. So let me give you an example to illustrate my point. So for instance, our patient comes in and is sort of depressed, has poor mood, or presents itself with some cognitive impairment or lack of motivation and fatigue. So what would you say is the diagnosis? Maybe go one slide back. So go one slide back. What appears to be here are truly neurological issues. We all agree, depression, cognitive impairment, lack of motivation. These are all really central issues. But is it really a neurological issue, or could there be another issue hiding under the surface? So keep in mind, a problem in the human body is never a standalone problem. Whenever something occurs in one system, it immediately affects all the other major systems. So the immune system can affect the nervous system, it can affect the endocrine system, it can affect the enteric system, and vice versa. So you have all those ramifications. It depends on your point of view. What I would like to do, and what I recommend for every physician, a primary analysis for most of the clinical conditions should always include the neuroimmune analysis. And this is the reason why. The nervous system really is a powerful tool. It's a tool for biomarkers. It connects the entire body, all the different parts, all the different organs, all the different functions we have in the body. The nervous system really is everywhere, whether it's in your toe or in your brain. It doesn't make a difference. As such, the nervous system picks up anything that might go wrong or has gone wrong in the body. So I will show you some examples how you can see that. And indeed, what I will propose here is indeed true. So whenever something happens in your toe, the brain knows about it within a split second, and vice versa. Next slide. I give you an example of a patient which I had tested a few years ago. It was an acquaintance of mine and or a co-worker, and one day he came into me and said, "Gottfried, I have to go home. I have a terrible, toothache." So I said, well, before you do that, let's collect a sample, a urine sample, and let's check out neurotransmitters. At that time, I didn't know that the nervous system or the check of neurotransmitters could really give me any information on that subject. But now this slide convinced me otherwise. I had tested this patient before, and you see here there is a column called before infection, and you see the various neurotransmitters here. which ones there are is not important at this point. And then I check the patient during the infection, and you see there is a dramatic differences for a number of neurotransmitters compared to the numbers what we call before infection. Glycine is different, glutamate is different, phenylethylamine is different, dopamine is different, norepinephrine is different, epinephrine is different. So, of course, the patient went to the doctor, got treated, and I think it was for the most part then antibiotics treatment. And then 2 weeks later, I checked the patient again, where he told me that he feels much better, and the dentist told him that there is no more infection going on in his tooth. And you see, the numbers are again returned back to normal. Glycine pretty much returned back to the normal level. Glutamate also for the most part, PA, and so on and so on. So overall, it shows you that the neurotransmitters can be a powerful tool. Incidentally, the common inflammation marker, which we all know so very well, the C-reactive protein, did not show any change. So in that sense, CRP is a relatively crude marker for inflammation. I have one more slide to make my point. Here is a slide of a different patient who presented himself with a urinary tract infection. Same story here. When you look at the numbers, serotonin had a level of 8.2. It should read 82, not 8.2. 82. During the infection, the level goes up, and after infection, once the treatment has occurred, it was also an antibiotic treatment for two weeks, things normalized again. And again, same story here. C-reactive protein did not react to it. Where, on the other hand, the nervous system really showed it a difference. So it is just to tell you and to show you that the nervous system really picks up anything, whether this problem occurs in the periphery, whether this problem occurs in your toe or in your head. The nervous system can pick it up, and it will. You can measure the change by a urinary analysis. So let's come back to a more fundamental question. What is it that could affect the nervous system and indirectly the neurotransmitter system? Because neurotransmitters such as the biomarkers and the signals of the nervous system. And we have quite an array of conditions here. It could be purely socioeconomic or psychological issues, but then we also could have issues, classical issues, such as infection or immune issues, a viral infection, bacterial infection, a fungal infection, and so on and so on. And then we could have other issues, injuries, trauma, concussions, or sensitivities to environmental factors, or there could be food issues, or certain chemicals we're in touch with, or certain medications, or last but not least, their organ dysfunctions. So what is the common denominator here? It's always the overriding issue is inflammation and oxidative stress. I try to show you another slide, and this is more a personal experience. A few years ago, I had to undergo a bypass operation, so of course, everything went well, badly, otherwise I wouldn't be here. But as a result of the procedure, they introduced some foreign materials into my body, to tie the ribcage together again. And unfortunately, this inclusion of the foreign material in the form of a wire that contains some nickel created a reaction, because genetics, as I found out later on, I had a sensitivity which was genetically controlled to a nickel. So within 4 to 8 weeks after the bypass operation, I contracted significant inflammatory issues, and I didn't feel well at all. But to make a long story short, a year later or so, I went for another operation to remove the foreign material and to replace it with something else. And you see, the nickel sensitivity first, the test confirmed, and at that time we did a ELISA test, that I was very high. I reacted very strongly to the insertion of nickel. And once the nickel wire was removed, the nickel sensitivity returned back to normal. Next slide. The clinical consequences are of the caused by the introduction of this foreign material, and we caused an increased anxiety. I was a little bit more depressed. I had much more insomnia before, and also I had the feeling my brain is not really very clear. The function is somewhat impaired. Needless to say that after the removal of the foreign material from my body, those issues for the most part went away. So here's an important lesson to be learned. True symptom relief always has to be accompanied by root cause analysis. So just imagine, I would have gone to a doctor and told him, well, I'm more depressed, I cannot sleep very well, or I also have fatigue issues. Or the doctor probably would have treated me with some antidepressant or some other medications. But I think that would have completely missed the boat. And this is what we're doing in traditional medicine, not always, but the majority of traditional medicine does not look at root cause. And I think this is paramount, that we reconsider how we work up a patient. Root cause, besides symptom relief, it is always important, it should be important, that we start asking the question, where does it come from? What's behind a fatigue issue? What is behind a depression issue? Yes, we all could have, we all could be, from a genetic point of view, be inclined to be a little bit more depressed than other people under the same circumstances, but still not in such a traumatic way. So, and the bottom line is, you see it in the insert on the bottom, if you don't really treat root cause, clinical conditions will never completely go away. They will keep resurfacing. Now, let's address briefly the question of what laboratory markers do we have at our disposition to check out inflammation. And as you can see here from this table, there are quite few. Of course, the first thing which we all are familiar with are the cytokines. And there's many cytokines in our body. There's well over 100. And then, however, not are equally important, or to be more honest, at this point, we do not even know what all those are many cytokines, what do they all mean and what their proper function is. But certain cytokines have crystallized out. So what we call the pro-inflammatory cytokines, and I just mentioned here a few, like IL-1, TNF-alpha, interferon gamma, IL-12, IL-17, IL-18, IL-6. And then we have as a counterpart, the so-called anti-inflammatory cytokines, and I just list there are two here, IL-10 and TGF-beta. Now, then we move on to the neurotransmitters. You would say, and that might be a novelty, you would say, well, how can that be, that neurotransmitters can be markers for inflammation? Right now, leave it as a statement. and I will explain to you afterwards why that is. Glutamate, our classical neurotransmitter, can also be a marker of inflammation. Glycine can be a marker of inflammation, histamine, norepinephrine, dopamine, VA, and quite a few others. So neurotransmitters in that sense have a dual function. Then we have other markers like sulfides coming from the neutrophils, are a marker of hydrogen sulfide. Then we have oxidative stress markers, and there we have quite a few. We have a DOPA, which is a metabolite of dopamine, 5-HAA, which is a metabolite of serotonin, chynurenic acid, it is in the pathway, in the tryptophan pathway. Quinolinic acid is part of the tryptophan pathway. And then we have other markers, strictly markers that measure oxidative stress load, such as the mitosort test, or as part of the mitochondrial function test. And I will come back to that one later on, because this is relatively new. Then we have our oxidized LDL. I think most of us are familiar now with that parameter. It's not really the cholesterol per se that causes a problem. It's the oxidized LDL that causes the problem. And in conjunction with that one, we also have the oxidized catecholins. And of course, we have C-reactive protein. Just as a sideline, there is a very close relationship between inflammation and oxidative stress. We have done a study to that effect of around 500 patients. And you see there is an extremely close correlation between inflammatory issues and oxidative stress issues. So when people talk about oxidative stress, then you always can conclude there must be some inflammation issue behind it. Let's briefly address the statement that certain neurotransmitters have a dual function, such as glutamate, glycine, norepinephrine, dopamine, epinephrine, serotonin. Now, this might be a little bit a novelty for many of you, and you might never heard about it, because if I had asked you norepinephrine, what kind of a biomarker is it, the majority of you would have told me, well, it's a marker of the nervous system. But if I had told you, no, it's also a marker of the immune system, you said, how is that possible? And indeed, it is possible. Our norepinephrine is also produced by the immune system independently and separately. Glycine, glutamate, dopamine, epinephrine, serotonin, and probably many more neurotransmitters are independently produced by the immune system. So you see, we have to ask ourselves, how is that possible? And by the way, those neurotransmitters, such as glutamate or norepinephrine produced by the immune system, is indistinguishable chemically from the neurotransmitters of the nervous system. So that makes the laboratory analysis, particularly the laboratory interpretation of those neurotransmitters and the meaning of it very difficult. Because when you measure those things in urine, but also by the same token, if you measure those things in plasma, you have to scratch your head and ask yourself, okay, is this now the norepinephrine, is it neurologically derived, or is it an immune-derived neurotransmitter? Next slide. Here is proof, and this is being published right now, that there is ultimate proof that the neurotransmitters occur independently in the immune system. So this is an LCMS analysis of those neurotransmitters being established from the PBMCs, the white blood cells. So there is no influence directly coming from the nervous system. So I think it seems to be really true that the immune system produces the same neurotransmitters as they occur in the nervous system. We do not know yet at this point what the connection here is, but it is now well established and confirmed that this indeed is the case. So keep that in mind. The immune system also produces the same or similar neurotransmitters as they do occur in the nervous system. Next slide. So now we have to ask ourselves the question, what connects the system, the immune system, with the nervous system? We do not fully know it or understand it because these are all relatively recent findings. I dare to say findings of the last 5 to 10 years. Some go back a little later than that. It's the free radicals. Free radicals is really the more proper term for oxidative stress. When we talk about oxidative stress, we immediately should think of an excess load of free radicals. So what are free radicals? Free radicals are, and there's quite a few in the body, are highly reactive chemicals, small molecules such as nitric oxide, the hydroxyl radicals, and the superoxide. So all those small chemicals, they're produced on a regular basis in the human body. And they're secreted as a result of a certain cytokine activation. Actually, every cytokine activation produces free radicals. Let's not forget that. Meaning cytokine activation is identical with inflammation. And consequently, you also put out additional or extra amounts of free radicals. Then the free radicals are also part of our normal living. ATP production in the mitochondria constantly and routinely produces free radicals. And there's quite a few other conditions that produce free radicals. Free radicals, are their friend or foe? You know, I would say they're both. They have the positive effects and the negative effects. Despite that I really do not want to use the word balancing, because this word has been abused by the supplement industry and so on, without really having proper scientific foundation. So the positive effects of free radicals are important in the immune system. They provide the defense against infectious agents such as bacteria, viruses, or fungal materials. They also are important as signaling entities of cellular functions. And then they regulate a lot of biochemical pathways. This should not be forgotten. The negative effects, meaning if you have too many of those free radicals around, they can damage your cell structures, such the membranes, the lipids, the proteins, the DNA, and they also derail important neuro, endo, and immune pathways. I show an example of the free output of free radicals in patients with Lyme disease. So Lyme disease as a prototype of infectious disease, and you see here in the right part that this is what we measured here was our superoxide load in those in patients with Lyme disease, and at the same time on the left side we have the controls, and you see there is a significant difference in the oxidative stress load or in the free radical load between the control group and the patient group. So what I said about Lyme disease is true for any infection that a patient might run into. So infection creates inflammation. Inflammation creates high output or increased output of free radicals. As a result of those findings, which has become possible, as a result of developing some new tests for mitochondrial function, we checked out the overall superoxide load in patients. So this was a random patient population. I do not know, I think we had around 100 people here. So, and then you see those levels were all over the map. On the left column, the blue part, this is just, the total subject. We had 86 here. And then we try to categorize those patients, which ones really have secrete lower bounds, normal bounds, elevated or high amounts. And you see at least 1/3 of this random population had an elevated output of those superoxides. And the superoxides definitely are not neutral. So meaning those 35% of these patients which were checked, definitely they have an issue and they definitely are at risk for some abnormalities. And those abnormalities could be either light or they could also be very much on the heavy side. So it's this is not a neutral issue. Next slide. Briefly coming back to the mitochondrial function assessment. What we did there, and this test has become available just recently. I do not know whether it's on the market or yet. So the test consists of the measuring the actual free radical load that occurs in the mitochondria. That is number one, the so-called mitosort test. And then we have a measure of that overall package in terms of measuring the plasma peroxidase activity. And then as a last part, we assess in this package also the mitochondrial membrane potential with a challenge. And the beauty of it is you can check out the patient to see how much of free radicals he or she can handle. And I was surprised when I looked at the results of this test that there are quite a few people they are not able to hold up or are under increased free radical stress. Meaning from a patient perspective, those patients need a high amount of antioxidants to deal with that issue. Next slide. So now I will show you a few slides of patients who have inflammation. So this is in general, a patient with inflammatory issues. So where you see the arrows are as a result of an acute inflammation, glutamate always increases. And for the most part, also glycine increases. Glutamate and glycine work closely together here. But you see also DOPA, the marker for oxidative stress increases. Then we have also a high level of epinephrine, because epinephrine is not just good for adrenal function, but it is good also as an anti-inflammatory response in the human body. So epinephrine really has two functions. No epinephrine in this test did not go up dramatically. Actually, it is quite low. And the reason for that one will be explained later on. Next slide. So here we have an example of a patient that presented himself with concussions, headaches, memory issues, cognitive decline, and so on and so on. The highlight here is, and the take-home message is, the majority of neurotransmitters were quite low. Serotonin was very low, dopamine was quite low, epinephrine was quite low. On the other hand, glutamate is still in the category of normal. Yes, glutamate is really only a marker during the inflammation process in the beginning. When the signal has been given from the white blood cells to the nervous system, then the glutamate returns back to normal. So be aware of, by assessing the glutamate numbers, you can really make an assumption how old the inflammatory issue is. If glutamate is still high, then it's still in a very acute and early stage. If your glutamate is disappearing and returning back to normal, then you know this has become a more chronic issue. The same is true for norepinephrine. But every inflammation in the end results in a depletion of a specific neurotransmitters of the nervous system. And this is where the neuro connection comes in. So there is an inverse correlation between inflammation and the level of neurotransmitters. The more inflammation you have, the more the more reduction you get in the in key neurotransmitters, particularly norepinephrine. Norepinephrine is your number one neurotransmitter that gets affected by inflammatory issues. But there are also dopamine, BA, and a few others get affected the same way. Next slide. So now here you have another patient who presented himself with PTSD. And the only medication he was taking was some migraine medication. But you see here, everything is still very red. The bars are still go all across the report. So that tells you this is still a very, very acute situation. This has not become chronic yet. Because all the things have really significant consequences for therapy and what should be done about the situation. The therapy for people with acute inflammation is quite different from the therapy that involve chronic inflammation. So next slide. Let's skip a few slides here, because I like to have some time afterwards for discussion. I'll get back to the previous slide. Yeah. The important part is whatever we do, and whatever treatments you invoke, whether this is a neurofeedback or any other treatments, are also chemical treatments. Say you would say a patient has low norepinephrine, so give the patient an SNRI. In this case, in this patient here, what you see on the screen, an SNRI medication probably will have very little, if any, because for those medications to work, there has to be a certain amount of neurotransmitter left in the system in order to guarantee a positive or therapeutic response. The same is true when you are using neurofeedback here. In this patient, my prediction would be if this patient would undergo our neurofeedback, you would see probably disappointing results. The patient would be refractory to the treatment. So keep this in mind, and that is really a consequence that in this patient, the system is so depleted that whatever you do, you get only to a limited degree positive results. What you have to do here in patients like that, where the whole system is depleted as a result of ongoing years and years of chronic inflammation, you first have to replenish the neurotransmitter stores, and then your treatment will become much more effective, and you will see really positive results. Next slide. Next slide. Let's skip over those things because we're running out of time here. The important issue here is your always neurotransmitters and all those things, and we have to start learning that have to be always seen in context. That's what I call network interpretation. Nothing in the human body works in a vacuum. Everything is interconnected. So for you to find out what is important, it doesn't make sense, for instance, just to measure serotonin or norepinephrine. Now, in order to do a network interpretation, you have to measure at least 6, I prefer up to 9 or 12 neurotransmitters to give you a clinical answer. So keep that in mind. It is quite different. It's the combination of several biomarkers which work as an entity to and create a so-called laboratory image that will guide you what you have to do or what you shouldn't do. Next slide. Another important issue, when the nervous system, as a result of chronic inflammation, is highly depleted, you cannot adjust. The system itself will not restore it on its own. The immune system, as a result of chronic or acute inflammation, will, for the most part, always restore itself to the original level. And many neurotransmitters will restore themselves to a normal and healthy level. However, there is one exception. Norepinephrine will not restore itself to a normal level, or a level which you had before you got sick, before you develop a clinical condition. So this is very important. The nervous system is only to a very limited degree self-restoring. You as a physician, you always have to intervene with some medication or supplementation, depending what the issues are, to restore those levels. And what we have seen so far, particularly for norepinephrine, this could be a lifelong situation. I've studied many patients over years and years and years who had, as a result of inflammatory issues or as a result of trauma, lower norepinephrine levels or lower epinephrine levels or low dopamine levels. Those parameters did not come restore themselves back to normal despite medication, despite intervention with supplementation or whatever. So that is an important message. Scientifically, we do not understand yet why the nervous system is so refractory to the kind of self-restoration, or if you help with medications, the system will not come back to normal. So that is something to be kept in mind. Next slide. When you do therapies, you always have to work on both systems. You have to work on the nervous system, but you always, particularly when the nervous system is derailed, as evidenced by some neurotransmitters, you have to conclude there is still a hidden immune issue behind it. So you have to work on both, pretty much as possible in parallel, on the restoration of the nervous system and correcting the immune system. Next slide. I show you a slide here which makes the situation even more complicated. These days, the use of antioxidants is very much in vogue. And now with the availability of the mitochondrial function test, where we really measure the actual radical load in the body, you would say, okay, now let's check out a bunch of antioxidants to see whether really they're all as good as they claim to be. And you see here in the first slide, there are 2 patients that were treated with one particular antioxidant. And you see in the patient on the green line that who had a high oxidative stress load. This patient responded very well and very quickly, within a week's time, to the excessive stress load, free radical load, returns back to normal. Of course, the red line here is in a patient that already had a relatively low oxidative stress load, so we do not see much there. On the other hand, when we used on 2 different patients, also other antioxidants, you see in the red line, this is a patient that is completely refractory to treatment. So antioxidants did not help him at all. Whereas the second patient responds after a delay of 1 week and then very quickly to an antioxidant treatment. We are just at the beginning to understand why that is and why patients respond differently to different challenges and why it is important to select the right antioxidant. So in a sloppy way, I used to say and to joke, not all antioxidants are created equally. So keep that in mind. And so far what we have seen from our own research, this seems to be true. Next slide. Here again are the oxidative stress load and the inflammation load in people with different medical conditions. On the very left-hand side in blue is the healthy controls. We have 62 patients there. And then we have various patient groups, such as people with viral bacterial infections, people with migraines, people with insomnia, people with fibromyalgia, restless leg syndrome, cardiovascular issues. So you see all those people have elevated levels of free radicals. So keep that in mind. There is I've not seen in all those major clinical conditions which I've studied so far, any patient that really have normal superoxide levels. Next slide. Here, and that is more as an aside, every patient who has a significant or is under significant oxidative stress as a result of inflammation, infections, or emotional stress should be tested for the ability to deal with free radicals, meaning that is also genetically controlled. As you know, we have in our mitochondria 3 major enzymes. We have the superoxide dismutases as a D1, 2, and 3. Then we have the catalase and glutathione peroxidase. These are all enzymes that neutralize or buffer the free radicals. And there is a significant difference among the patients in terms of the occurrence of SNPs. The superoxide dismutase shows a frequency of around 30%. So you can assume every third patient that comes to you with significant inflammatory issue is not able to deal with free radicals in an appropriate way. Next slide. Here, the genetics plays a significant role in the inactivation of free radicals. So on the left-hand side, we have a control group, and on the right side, we have a group that is genetically disadvantaged, meaning at this point there are heterozygotes and there are also homozygotes. So you see there is a difference in people, and genetics here in this situation plays a significant role. This is just to highlight that one should not forget not all people are created equally. Next slide, at least from a medical point of view. So in conclusion, I have to say there is a paradigm shift in medicine. In that sense, linear medicine, which we have practiced for the last 50 years, is really going out the window. We have to think in much more complex terms. We have to think in a circular way. We have to go from symptoms to systems. And as you can see on the right-hand side, when the patient presents himself with a particular symptom, there could be all 4 major systems involved or only 1 or 2. So the human body is not easy, and it is a complex instrument. But I'd like you to get a feel for it, and hopefully what I just presented in this limited amount of time should be a little bit of an eye-opener. And for those people who know all those things already, I apologize. It should be kept in mind that this is a complex situation which we have But I think things, although they become more complicated on a biological and medical level, I think when you take all those things into consideration, you see much more positive clinical outcomes than what you've seen before. On that note, I would say, since we have only a few minutes left, let's use those remaining 5 or 10 minutes for questions and answers.
Okay, that was excellent, Dr. Kellerman. And you're preaching to the choir here. We very much have been talking about oxidative stress and the body, the immune, and the nervous system as systems of the endocrine system. And this is very supportive of how we've begun to think about it and discuss it. So it's delightful to hear it from somebody who specialized so long in it. Does anybody else have any questions, comments? Rick Mills, Kathleen. I'm undoing you, Kathleen. There you go. It's very good. I was delighted to see your discussion of the relationship of neurotransmitters to oxidative stress, the inflammatory process, and how interactive they are. We see the effect of these not as well as in direct testing, but we see the reflection of them in the brain mapping, the QEEG we do.
Okay.
So, Richard, this is...
Go ahead.
Yes, sir. You made the statement that if there's certain kinds of inflammation, then the neurofeedback wouldn't work. Was that because of the use of the neurotransmitters for the inflammation and that they wouldn't be available, i.e. dopamine might not be available for the neurofeedback? Or?
Yeah, that's exactly what I'm saying. You have to have a certain amount of neurotransmitters in the system, whether this is in the periphery or in central, for this kind of therapies to work. This issue has puzzled us for quite some time. Many years ago, when we started out on those issues, where we used the so-called SSRIs and the SNRIs, and we are puzzled by the fact that not all patients really responded very well to it. And in some patients, this kind of treatment didn't have an effect at all. So scientifically, we were really scratching our heads. And now, so now we understand why that is. And I think the same is true. And here I'm making a few assumptions, but from my end, I would be very much interested in getting my hands on more patients who are refractory to treatment. So I think that would be an interesting and very beneficial exercise and experiment to do.
Yeah, I think it's interesting too, because I mean, for instance, the autistic population, I mean, it's hard to find an autistic child that doesn't come in with massive amounts of inflammation.
Yeah. So the autistic population, what we've seen so far, they all have inflammatory issues, all, and to various degrees. They also have high oxidative stress loads. They have a lot of free radicals floating around in their system. And the way I see it, and what I advise the doctors, is always keep the oxidative stress load as low as possible, because there is so many pathways in the body, not just in the periphery, but also in the brain, which are regulated by free radicals. For instance, the entire catecholamine system of the nervous system is clearly regulated by free radicals. This has to be kept in mind. So that's why I always say the free radicals in those patients should be suppressed as much as possible. It will not be impossible. It's almost impossible to suppress it completely, because due to the inflammation process, you constantly generate new free radicals all the time. But if you do this on a daily basis, you definitely will see some progress.
Thank you so much.
You're welcome.
Yeah, I have a question. When we do these tests to measure neurotransmitter levels, what can we tell in terms of what's going on in the brain particularly?
This is difficult. So here, this is what we have learned. Of course, we cannot open up the brain, and even if you could, it would not help us, because the minute you open up the brain, you create a completely different scenario when it comes to neurotransmitters. What we have seen, there is a close connection between our peripheral measurements and clinical symptoms of the brain. So when you have low norepinephrine levels, as evidenced by urinary measurements of norepinephrine, we see those people have a bunch of symptoms in the periphery, so we can verify that one. So, but the question always was, how do we know those same low peripheral levels are also representative for what's going on in the brain? So I think we have tested thousands and thousands of patients that are in the background of this question. And as of today, I dare to say that really when you have a peripheral measurement of low norepinephrine or low dopamine, then you also have the similar low levels in the brain. Of course, I cannot say where in the brain those levels are low. Remember, the major center for the neurotransmitters is controlled in the brain stem, and as part of that in the locus coeruleus. So if that is low, then you can assume that there are everywhere in the brain there is suboptimal or deficient level of certain neurotransmitters.
So we're making an inference based on what we're finding peripherally?
Yeah. So really you can assume if you see on a report low norepinephrine levels, or you can assume those are low epinephrine levels or norepinephrine levels seem to be present in the brain.
Thank you so much.
Okay, you're welcome.
Can peripheral neurotransmitters cross the blood-brain barrier?
No, not for the most part. That do not. Also, what we're measuring in urine or in plasma, there is very little that comes from the brain. First, the concentration of brain neurotransmitters is relatively low compared to what we see in the periphery. So maybe it's just 1 or 2 or 3%. We are not sure at this point. But it really makes no difference whatsoever, and they have no influence on peripheral measurements. So it's all interference and all extrapolation. That's what we're doing here.
Thank you.
All right. Well, we probably need to wrap this up, Dr. Kellerman, because it's a bit after 1. But thank you so much for your time today.
Okay.
And